Alrighty, so this is going to be over several chapters in your Understanding Medical Surge Nursing book to cover the adults, but we're not doing all of the chapter of each. So we're going to do, I think, 36, 37, and then I believe there's another one, but we're only covering a few things out of the men's. So we'll start on chapter 36, urinary system function, data collection, and therapeutic measures. We have our learning outcomes, identify the normal anatomy of the urinary system, describe the normal function of the urinary system, discussing the effects of aging on the urinary system, and explain data to collect when caring for a patient with a urinary disorder. Okay, so also assisting in planning, preparation, and post-procedure care for patients undergoing diagnostic tests of the urinary system, assisting in planning nursing care for the patients with incontinence, and discussing nursing actions to decrease the risk of infection in our catheterized patients. So we're going to discuss elimination in this chapter. Quick overview of the anatomy. We've got our two kidneys, two ureters, our urinary bladder, and our urethra. Here we have a picture of the interior of the kidney. Our renal cortex, that's the outer layer of our kidney, the renal medulla, our inner region. We have our renal columns, the extensions of the cortex that divide out the medulla into cone shapes. We have our renal pyramids, the cone-shaped structures that make the tubules that transport the urine from the cortex to the renal tip, the papilla. The renal papilla, the tip of each pyramid, which drains urine into like a cup-like structure. And then we have that minor calyx, which is going to collect our urine from the renal papilla. Our major calyx, it's going to form when two or three of the minor ones start to join together. And then our renal pelvis, that's where all of the major calyx converge, and that channels our urine into the ureter and then draining out to the bladder. Okay, so urine forms in our cortex, and then it's going to flow through the pyramids, exit the papilla, drain into the minor calyx, calyces, however you say it, join into the major ones, collect in the renal pelvis, and then go down out the ureters to the bladder. Next, we have a little anatomy overview of our nephron. So this is going to, it shows our blood flow through our nephron. So our nephron, we know, is our kidney's functional unit. We have the afferent arteriole that's going to bring the blood into the nephron from smaller arteries in the cortex. The glomerulus, that's a capillary cluster inside the Mobin's capsule where filtration occurs. The afferent arteriole, that's going to carry blood away from our glomerulus. The peritubular capillaries, that's a network of capillaries surrounding the renal tubules. They reabsorb water and solutes and filtrate. Our renal vein, that's where we're going to have blood flowing out of the peritubular capillaries into larger veins, and then eventually joining the renal vein. So a summary of this: blood enters the afferent arteriole, filtered to the glomerulus, exiting the afferent arteriole, exchanges in the renal tubules and the peritubular capillaries, and then drains into the veins and goes back out to circulation. So the functions of our kidneys: formation of urine, so filtering the blood and removing waste; excretion or conservation of water, so regulating our fluid balance depending on what our body needs at that time; electrolyte balance, maintaining proper levels of sodium, potassium, calcium; and acid-base balance, helping control our blood pH by excreting hydrogen ions and reabsorbing bicarbonate. Just remember that your hydrogen ions, those are going to be your acid, your bicarbonate, that's your base. Activation of vitamin D, so converting it to its active form for calcium absorption. Production of erythropoietin, that is also abbreviated EPO, erythropoietin. That's a hormone that stimulates our red blood cell production and bone marrow. And then the production of renin, that's an enzyme involved in our blood pressure regulation from the renin angiotensin aldosterone system. So kidneys are going to regulate our waste, our fluid and electrolyte balance, pH, hormones, blood pressure, and they are going to be vital for our homeostasis. So our glomerular filtration rate. So our renal filtration filtrate in the kidneys, they form in 1 minute. This is going to average to be around 100 to 125 milliliters per minute. So they're really kind of cranking that through. Next, we have a picture of the glomerular filtration. So this is explaining the process of it in the nephrons. So the high pressure blood flow is going to go through. So it goes to create a high pressure blood flow. So our blood's entering the glomerulus via the afferent arterial, and that's going to create high pressure, which is going to force fluid out of the capillaries. We have the filtration at the glomerulus, so that's going to be our, we understand that our capillary walls have these pores that allow the water and small solutes like electrolytes, glucose, some amino acids, vitamins, and nitrogen waste to pass through into the Bowman's capsule. We have larger substances like blood cells and plasma proteins that are going to remain in circulation. And so that's where we end up with our glomerular filtration rate, so our GFR. This is where the filtrate moves into the renal tubules, and then together our kidneys filter about 180 liters per day. So that's about 60 times our blood volume. About 99% of this is reabsorbed, leaving only 1 to 2 liters of urine daily. So in short, blood pressure drives filtration, small solutes and water enter into the Bowman's capsule, and then most of the fluid's reabsorbed, and what's not comes out as urine. Okay. So a little overview on, if I can get it. Okay, so our ureters, these are the tubes that are going to carry the urine from our kidneys down to our bladder. Our bladder is going to serve as a temporary storage of urine until we're ready for elimination. And then the urethra is going to be that final passageway that carries the urine from the bladder outside of our body. So kidneys make it, the ureters transport it, bladder stores it, and then our urethra is going to be the exit. Normal urine characteristics. So we make about 1,000 to 2,000 milliliters per 24 hours, so about a liter to 2 a day. Color, it can range from very pale yellow to amber. Appearance would be clear. Specific gravity is going to be 1.005 to 1.030. So the lower the number, so this end is going to be more dilute, and then the higher is going to be more concentrated. Alrighty, our normal pH of our urine is going to be about 4.5 to 8, and it constitutes about 95% water, with our waste products being the urea, creatinine, and then uric acid. This little pathway here is just talking about the aging of the urinary and renal system, but we talk about that a little more on the next slide. Okay, so aging in the urinary system, our renal mass is going to get smaller, so our kidneys are going to shrink with age. We can expect our renal flow, so our renal blood flow, to decrease by about 50%, so we have less filtration capacity. We have a decrease in our tubular function, which is going to lead to the reduced ability to concentrate the urine and regulate our electrolytes. We have our bladder muscles weaken, so that's going to lead to complete emptying and retention. Our bladder capacity is going to decrease, so we have the smaller volume of urine that can be stored. And then our voiding reflex is going to become delayed. So slower response increases the risk of that urgency, frequency, and incontinence. So summing it up, with aging, our kidneys are going to filter less efficiently. Bladder is going to hold and empty less effectively, and then that's going to contribute to urinary problems with our older adult population. Okay, so this is gonna kind of outline our assessment considerations for kidney disease. So our kidneys are going to affect all of our body systems. So it's not just going to be urinary that's affected, but our cardiovascular, respiratory, and our metabolic health. When we're gathering a health history, we need to ask about past illnesses, current and past medications, and then risk factors. Um, we need to ask about any pain in the flank area, so that can indicate infection, whether they have stones that are present or any kind of obstruction. We need to ask about any burning with voiding, because that could also suggest infection and irritation. Ask about any new onset of edema, shortness of breath, weight gain. These are going to be signs of fluid overload and declining kidney function. We want to ask about their fluid intake, so asking what their hydration patterns are, and just their overall functional ability. So assess how the kidney disease is impacting their activities of daily living. Okay, so whenever we do our assessment, we want to take this beyond just the kidneys and urine. We need to evaluate the systemic effects. Well, no. There we go. Okay, so objective data that we can gather. Our vital signs, so we can expect our blood pressure to increase. That's pretty common due to the impaired fluid and sodium regulation. Lung sounds, crackles can be heard, indicating that we have fluid overload and possibly some pulmonary edema. We can expect some swelling. That's common in the extremities and just generalized overall. Another sign of our fluid retention. So hypertension, crackles, edema, those are going to be major clinical clues that we have some underlying kidney disease and fluid imbalance. Some more objective data that we can gather is their daily weight. That's going to be a good indicator of their fluid balance. Their eyes and nose. So these are critical to track, since some medications and fluid therapies can depend on these accurate measurements. We want to look at their skin. What are they looking like? Do they have a yellowish or grayish discoloration from toxin buildup? Do they have kind of a frosty glow to them, like they have the crystals or urea? I worked on a renal unit whenever I started. That was my first nursing job, and we always joked that this is not great, but like they would have that renal glow to them whenever they would skip dialysis. So you could just see the toxins build up in them. So a skin assessment can tell you a lot about somebody's kidney function when they have kidney disease. So careful monitoring of their weight, fluid balance, and skin changes are some good objective data we can collect. So a urinalysis, I said this in the PEDS lecture, but I have a table under the urinary section where we have the diagnostics, so our labs, and then any imaging. It's going to say what it is, what it's used for, why you're using it. So just kind of getting you down to the nitty gritty. And then I think your ATI med-surg, adult med-surg one has a good table in there too. So urinalysis, in an ideal perfect world, this is going to be our first morning specimen, unless used for cytology. So that's preferred because it's going to be the most concentrated. If we can, we want to get a voided clean catch or a sterile catheter specimen. Usually about 10 milliliters of urine is going to be sufficient for testing. When you send off a UA, you want to send it very quickly because they need to look at it within an hour of the collection. My point was proper handling of this is crucial for your results. So a 24-hour urine collection. Some of you may have done this in the hospital. You have that big like orangish brown jug. So when that starts, you're gonna have your patient void and discard their first urine, and after that void starts your official start time. So during the 24 hours, all urine is going to be collected into this container, and that container is placed in the refrigerator. If you miss any urine during that time, the whole study's void and you'll need to start over. Okay, so that's important point to tell your patients. Okay, so at the end of the test, you'll have at 24 hours try to have the patient void again, and this urine is going to be added into the container, and then everything after that will not need to be. So you're going to say we're going to start at 4 o'clock, our patient urinates at 4 o'clock, we're going to discard that one, start our time at 4 o'clock, and then anything until 4 o'clock, until 4 p.m. the next day, we're going to collect. And if we don't collect all of it, it's void. Okay. With our urine culture, we are going to identify any pathogens present with that. So the purpose is to identify any bacteria or yeast that could be causing infection. The specimen must be collected before giving any anti-infective medication, otherwise your results can be altered. So we're going to collect that and then have sensitivity testing to determine which anti-infective, whether it's an antibiotic or an antifungal, will most effectively destroy our pathogen. So our urine culture, we have two parts. So we're going to find the bug and then what's going to be best to treat the bug. Okay, so here we have the case study for the SBAR handoff report. I think that these are more beneficial for you to take the time and read through them and try to work them out on your own. And I think sometimes going through the content and then circling back to look at these is more beneficial for you, since you'll have a better understanding of the concepts, you'll better know how to work through that. And if you have any questions about these, as always, you can take a screenshot or refer to what slide number it is and we can go through it together. I'm always willing to do that. So we'll skip through these. Okay, so next we have those renal function tests. So more of our labs. We have, these are on the that table that I put into. Okay, so our BUN, our blood urea nitrogen, that's measuring the nitrogen from the urea, reflecting protein metabolism, and our kidney clearance. Our serum creatinine, that's going to be the best routine indicator of kidney function, since our creatinine is normally filtered and excreted. Okay, so when it's elevated, we know that we have some damage. The serum uric acid is going to be elevated in kidney dysfunction or conditions like gout. And then our glomerular filtration rate, the GFR, that's going to estimate our kidneys filtering capacity. So that's going to be a key measure of our renal function. The creatinine clearance test, that's going to compare the blood and urine creatinine to help us more precisely assess the filtration efficiency. But again, those are all in a table to help you better understand them. Okay, so we have an activity here. And again, email me if you have any questions, and then we'll pick up with renal biopsy. So the purpose of our renal biopsy is to provide detailed information about kidney disease. This is where they're going to go in and take a small section of that renal cortex. It's usually going to be through a needle that is inserted through the flank. That'll give them a good analysis. So contraindications, we are not going to perform this on somebody that has a risk of hemorrhage, so bleeding tendencies, uncontrolled hypertension, that's going to increase our bleeding risk, or if they only have a solitary kidney, because we don't want to risk losing their only functioning kidney. So renal biopsy helps us diagnose kidney disease, but it's avoided when the procedure poses too much risk. Okay. Alrighty, so for the renal biopsy, we want to explain to our patient how it's going to be done. So they're going to try to do it percutaneously or make a small incision in the flank. So make that small incision and then put the needle biopsy through. So what we're going to do before, we are going to ensure that our patient is NPO before our procedure. Explain to them that they will be sedated slightly. So it's going to be kind of like your conscious or your twilight sedation. After the biopsy, you're going to, of course, check your dressing, see, mark as they come out if there's any drainage coming through. So monitoring your pressure dressing. They will have frequent vital signs done, and we're going to observe for bleeding at that biopsy site. When they first void, if they have any blood in their urine, we want to let somebody know, because that can signal that there was some complications. So before a biopsy, we want to prep them by being NPO and explain sedation, and then after the biopsy, we want to monitor closely for bleeding and then hemodynamic stability. So next we're going to talk about the radiological studies. There's a kidneys, ureter, bladder. This took me way too long. So whenever they'll order it, they'll say a KUB, and it took me like years before because I knew what they were looking at, but I never put it together. It was like kidneys, ureter, bladder. So this is going to help us visualize our urinary tract. It's going to help detect any tumors, swelling from like hydronephrosis, and then help us diagnose kidney stones. So in short, this is just going to be a simple structural abnormality test, okay? So we're looking for obstructions or any structural abnormalities. Some of your older doctors are more well-seasoned. They could refer to it as a flat plate or a scalp film. Heard those. So next is going to be our pyelogram. So this is going to be an imaging study of our urinary tract. So renal pelvis, our calces, the ureter. It's going to help us visualize the drainage structures of the kidney and detecting any blockages, stones, tumors, or abnormalities. So we can have a couple different types. We can have an IV pyelogram where we have contrast dye that's injected intravenously, and then serial x-rays are taken to track how it's filtering and excreting out. We can have a retrograde pyelogram, so the contrast is introduced directly through the ureter via a catheter. So this is usually done during cystoscopy. We have the antegrade pyelogram, so contrast is placed into the renal pelvis by a percutaneous needle puncture. So pyelograms showing our kidney drainage pathways and if we have any blockages or abnormalities. So that's your drainage. Okay. For our IV pyelogram, things that we want to ensure is that we're checking for any contrast allergies. We're going to look at their serum creatinine before to ensure that their kidney function can handle the contrast. We want to look at the patient's hydration. They need to be well hydrated before and after the procedure to help flush that contrast out. Contrast is pretty hard on your kidneys, so we want to protect them the best we can with the pre-flush and then the after-flush. So this contrast media is injected through the IV to help outline the renal structures on x-ray. So it's showing how our urine is going to flow through our kidneys, ureter, and bladder. Okay, so we're using the contrast dye to check for the movement of urine. Alrighty, so hopefully I've had my last wardrobe change for this urinary series. Okay, here we go. IV pyelogram, this is going to be a KUB with contrast. So we are able to look at the outline of, we see our, well, I guess I can't point. Alrighty, we see our spine here, but we can see the contrast, how it's moved down to the bladder. So here we're looking for trying to detect any abnormalities, structure problems, looking for swelling, tumors, kidney stones, things like that. Let me find my mouse again. Okay, so for our renal angiography, we want to check for allergies prior to testing. So any iodine or contrast allergies, we want to check our patients' creatinine and GFR to ensure that their kidneys can handle the contrast media because it is pretty hard on our kidneys. And then we have our procedure. This is where we're going to use the contrast dye to visualize our renal arteries. So it's going to help us track the blood flow to detect any narrowing, blockages, aneurysms, or vascular malformations. So after our test, what we want to be doing is checking our distal extremity pulses to ensure that we have adequate circulation. We want to monitor the dressing site for any bleeding at the catheter insertion site. So our renal angiography is going to be contrast dye plus imaging to evaluate the kidney blood vessels. Okay, but monitoring for bleeding is an important thing with this one. So next we're moving on to contrast-induced acute kidney injury. So contrast can be nephrotoxic, meaning harmful to the kidneys. Some potential effects is it can cause a kidney injury in high-risk patients. It can often lead to a rise in serum creatinine just in your normal population. So that's why we want to encourage patients to drink plenty before and then plenty after to help clear that contrast. Many times patients can be asymptomatic with a contrast-induced AKI. So risk factors for this are going to be an already low GFR, so showing that we have renal impairment, and then a low GFR with diabetes. So that's going to be an increased vulnerability. But we also want to look for concurrent use of nephrotoxic drugs. So things like NSAIDs, aminoglycosides, some antivirals. Then we want to watch out for metformin with giving contrast, holding that after. So our contrast dyes pose the greatest risk to patients with pre-existing kidney disease. Diabetes are those that are on nephrotoxic drugs. Next up, I think, is an activity. Of course, work through these. Oh, it's one about, decreased GFR, taking metformin. What do? We want to hold the metformin afterwards. Okay. Okay, so now taking a look at our endoscopic procedures, we have cystoscopy and a pyelogram. So a cystoscopy is going to be inserted through the urethra into the bladder. So we're taking a scope up, and then a retrograde pyelogram is going to be performed by injecting contrast directly into that kidney pelvis via the ureter. So we have x-rays that are then taken during these to visualize the urinary tract. So post-procedure care that we want you to worry about is to monitor the urine output carefully to ensure there's no obstruction or retention or bleeding. Okay. So this is going to combine direct visualization with that scope and then contrast imaging with the retrograde pyelogram. So they go together. Okay, so looking at the renal ultrasound now, this is going to be non-invasive. It's going to use sound waves to examine the anatomy of our urinary tract. There's no special preparation that needs to be done for this. So it can help us identify kidney enlargement, kidney stones, chronic infections, tumors, or masses. The good thing about our renal ultrasound is it's safe, it's simple, and it is our first-line imaging tool for detecting structural abnormalities. Okay, next few slides, or no, just the next one. We have some nursing diagnosis. Alrighty, so we're at incontinence. So we have a couple different kinds. We have stress incontinence, and this is going to be caused by involuntary urine loss due to increased abdominal pressure. So this is often triggered by things like coughing, laughing, sneezing, or physical activity. Our urge incontinence is going to be caused by involuntary loss associated with a sudden strong urge to void. Patients will usually describe this as just not being able to make it to the bathroom in time. So in short, our urge incontinence is leakage with pressure or activity, and our stress incontinence is leakage with pressure or activity, and then urge incontinence is going to be leakage with a strong sudden urge. So those are pretty easy to keep straight. So we have disability associated incontinence. So this is going to be caused by an inability to reach a toilet due to health problems, environmental barriers, or physical or mental limitations. So this is not going to be a bladder or urethra issue, but more of a mobility and access issue. We have overflow incontinence, and this is going to be caused from bladder overdistension, so involuntary leakage of urine when the bladder becomes overly full. This is often seen with an obstruction, so an example is an enlarged prostate, so obstructing that, and then you also have impaired bladder emptying. Total incontinence is going to be a continuous, unpredictable loss of urine, so this is often seen with neurological dysfunction and structural abnormalities. Okay, we have more nursing diagnosis. And then we have urinary retention. So acute causes of urinary retention can be anesthesia. This is temporary suppression of bladder contractility after surgery. So sometimes whenever a Foley is placed during surgery, the nurse giving a report will say, you know, we pulled the Foley at this time, they need to void by this time. So whenever you hear the phrase due to void after surgery, that's what that means. They need them to get up and use the restroom, empty their bladder after having that Foley placed. But even without the Foley placed, sometimes you can get urinary retention from anesthesia. It's pretty common with kids too. So also acute causes local trauma to urinary structures, so swelling, bleeding, or pain that's interfering with bladder emptying. Some medications can cause retention, such as anticholinergics, opioids. Those can impair our detrusor muscle function. Chronic causes for retention can be an enlarged prostate, so BPH, so we have a mechanical obstruction of the urine flow. Some medications, long-term use of drugs with urinary retention can be a side effect. Strictures, so a narrowing of the urethra from scarring or chronic inflammation, so that it's just having a harder time pushing through. Or a tumor, prostate, or pelvic mass that's compressing the urinary flow. So with our urinary retention, we want to monitor their urine output. We want to track this, whether it's hourly or per shift. That reduced output can indicate some retention or obstruction. And then we also want to check for bladder distension, so we can assess that through a palpation, checking for fullness or discomfort. We can bladder scan. This is going to be a non-invasive ultrasound that helps us check that I cannot think what volume we're holding in our bladder. So sometimes we will do a post-void residual, and that's where our patient will void, and then we have them lay down, do a bladder scan, and see how much their bladder is still holding. So when we have residual volumes of more than like 150 to 200, that can indicate the need for treatment, because we don't want that just sitting stagnant in the bladder to lead to a UTI. So urinary catheters, we have indwelling that we can talk about. So with indwelling catheters, we want to have a justifiable reason for why it's there. A lot of hospitals will have a nursing-driven protocol to pull an indwelling catheter as soon as you can to help prevent a CAUTI, so a catheter-associated UTI. So justifiable reasons to place these would be burns, so we can accurately track their output, people with neurogenic bladder conditions, we'll want those for long-term management. When we have a patient experiencing shock, we will need them, I want to say shock or just your ICU patients that are needing more critical monitoring to know hourly how much they're putting out. So for our strict fluid and urine output monitoring, and then for urinary tract obstruction, so the inability to void due to an obstruction being there. So we never want to place these because of incontinence. The only time that you do see them placed for incontinence is going to be more of your end-of-life care, palliative. So giving that patient comfort whenever they are in an end-of-life stage. That would be an appropriate use of it, but you're using it for the right reasons. So urinary indwelling catheters, they increase the risk for infection. So we want to get those out as quickly as we can. The risk rises with the longer duration. So this is another reason why we want to use strict aseptic technique in our when we're performing our skills, okay? Intermittent catheterization, this is going to be the best. So you would think because you're going in and out, that you would increase the risk for infection, but actually not having that direct access into the bladder constantly reduces the risk of infection. So the numbers are pretty comparable. Like, there's a big difference. I don't know the numbers off the top of my head though. So patients can learn how to self-cath, and they'll just get on a schedule. So some of like your neurological conditions, they'll just have a routine where they will self-cath every 4 to 6 hours. That's not uncommon. It just helps the person maintain a sense of normalcy for their life. Our suprapubic catheters, so that's going to be an indwelling catheter that's inserted through an incision in the lower abdomen into the bladder. This is going to be useful whenever urethral catheterization isn't possible or long-term drainage is needed. So again, the examples that I've seen suprapubic catheters placed would be like spinal cord injury patients. I've seen them in some MS patients. So where we need long term, but we don't want to have that urethral catheter indwelling. So the nursing care that we want is to monitor our dressing for that, keep a site clean and dry, and then secure the catheter to prevent any pulling and reduce tension on the site. So one thing that I want to kind of circle back on with the indwelling catheters is those stat locks are great, but whenever you, especially on like males, whenever you have them like placed tightly though, so where it has a lot of tension, you can get kind of like a splitting effect on the penis from where that catheter is kind of pulling down. And the same with women, if it's kind of, you know, not resting tight, but has a lot of tension against the labia, so you can get a pressure ulcer right there from the catheter. Yeah. So the role of the LPN will be collecting specimens for diagnostic testing, checking for urinary tension, whether that's a bladder scan, ultrasound, palpitation, and then inserting, maintaining, and removing urinary catheters. Then providing care to the client for bladder control management. We have several questions, and I'll try not to get too ahead. So please go through those. And then if you have any questions on why an answer is something, please reach out. I'm trying to make these videos as short and sweet as I can. Okay, so we're moving on to chapter 37, so our nursing care of the patients with disorders of the urinary system. So we have our learning outcomes here explaining the predisposing causes symptoms, lab abnormalities, and treatments of UTIs, explaining the predisposing causes, symptoms, treatments, and teaching for kidney stones, listing risk factor for signs of cancer of the bladder, listing risk factors for signs and symptoms of cancer of the kidneys. We want to discuss nursing care for the patient with an ileal conduit or a continent reservoir, explain the pathophysiology and nursing care for diabetic nephropathy, nephrosclerosis, hydronephrosis, and glomerulonephritis. We want to describe the signs and symptoms for patients with an acute kidney injury, and then we want to describe the signs and symptoms for patients with chronic kidney disease. Oh, and we have more learning outcomes. Woo! Okay. Assisting and planning nursing care for patients with acute kidney injury, assisting and planning nursing care for patients with chronic kidney disease. Discuss nursing care for vascular access site, assist with patient planning for hemodialysis, and assist in nursing care for patients on peritoneal dialysis. We have our chapter concepts, elimination, fluid and electrolytes, infection, teaching and learning. Okay, so we're going to move into now we're going to move into UTIs. Okay, so we have an invasion of bacteria in our urinary tract. The urinary tract normally is sterile beyond the urethra, but bacteria can ascend from the external urinary meatus into the bladder. So it's going to be an ascending infection, so going up. This is going to be our most common acquired hospital infection. So these are strongly linked to catheter use. So that CAUTI that I was talking about, and E. coli is going to be our most common causative organism. So looking at some risk factors, nope, that's the next slide. Okay. So risk factors: incomplete bladder emptying, contamination from wiping from the perineal urethral area, instrumentation, reflux from faulty valves, previous UTIs, female anatomy, age changes, genital piercings, are common signs and symptoms. So we're going to have that urinary urgency, frequency, burning. We can have cloudy urine that is foul smelling. We can have hematuria, pelvic pain. With our older adults, we have fatigue, confusion, delirium. With cystitis, we have a lot of those common signs and symptoms that are up here, but also the pelvic pressure and pain. With pyelonephritis, it's common to have those, plus the gastrovertebral tenderness. So that is going to be at like your 12th rib. Well, you can't see. Okay, so like down by your 12th rib on the back where your kidneys lie behind. So that, well, yeah, you can see. Okay, so about right here. All right, don't make fun of my pajamas. So, the types of UTIs that we have. Move to that. Well, maybe. Okay. We have urethritis. That's going to be inflammation due to infection, irritant, trauma. So, infection that can be often sexually transmitted organisms. We can have chemical irritants or trauma from catheterization. So that's going to, most common cause is going to be the dysuria. So burning with urination, frequency, and then possible discharge. The cystitis, that's going to be inflammation of the bladder wall, and that's usually from a bacterial infection like E. coli. So your symptoms with that's going to be the dysuria, urgency, frequency, suprapubic pain, and hematuria. Your pyelonephritis, that's going to be an infection of one or both kidneys. That's going to be from an untreated lower UTI that ascends into the upper urinary tract. So with this, we're usually going to have fever, chills, flank pain, and then that costovertebral angle tenderness that I was trying to show you. We can also have nausea and vomiting and malaise with this. Complications, this can pretty quickly escalate to sepsis. Also, it can lead to renal scarring. So try to think of it as a progression. So we would start here and we can progress up. So starting at our urethra, progressing up to the bladder, and then moving into the kidney. From here, we can get septic pretty quickly. And that's what we're moving to next. So urosepsis. This is often caused by a UTI. It's more common in older adults, especially those that have indwelling catheters. It's more common in our older adults that are diabetic or have urinary retention that does not require a catheter. But this can be a pretty serious life-threatening condition. We can have fever, hypothermia, tachycardia, tachypnea, hypotension, and altered mental status. I know several of you work in healthcare, so you have probably experienced the older adult with a UTI. It can be very upsetting for families to witness that, so it's good to kind of give them I know that this is not, your mom or your dad, they would never act like this, but this is what the UTI does. This is once, our antibiotics are kicking in and treating it, this will clear. This is not their new normal, okay? So we want to recognize early the signs of systemic infection with our patients with UTI, so these don't progress to like a septic shock and multi-organ failure. So we want to monitor their vitals, monitor their mental status closely, obtain urine and blood cultures before giving antibiotics if possible, and we want to do some prompt IV fluids as well. So if needed, do not be afraid to call a rapid on your, urosepsis. If they're starting to have a fever, get hypotensive, these are, your signs that you're getting in serious trouble. So that's a completely appropriate. With Epic, I know that I forget what it's called, but you get kind of a warning like, hey, you charted this and this, do you want to send a message? But also, like, you can send a message for the rapid team, I believe, at UK, but also it sends like a flagged message to the physician so they can also see that, hey, something might be building. So for our predisposing factors, once again, it's going to be that catheter, any recent urinary instrumentation and surgery. We want to take a look at their voiding patterns, then go through their signs and symptoms. Are you having urgency, frequency, burning, any foul-smelling urine, hematuria, pelvic pain? We want to inspect their urine, look at it for volume, color, concentration. Is it cloudy? Is there any blood present? Does it have a foul odor? Okay, so our urinalysis, again, that's going to be looking for leukocytes, nitrates, our white blood cells, red blood cells, our urine culture, that's going to be identifying our organism, and then the sensitivity is going to be guiding our antibiotic therapy. And then we have some nursing diagnosis again. Okay, nursing care, we want to administer those microbials, antimicrobials as ordered. We want to be sure that we complete the full course to prevent resistance and monitor for allergic reactions and side effects in our adults and kids. I don't know why I said that. Okay, provide pain control. Sometimes warm compresses to the suprapubic area can reduce discomfort. We want to make sure that we are careful with ever giving heat with our patients that have neuropathy. That urinary analgesics, so the pyridium, that can help to relieve some burning and dysuria. That's the stuff that turns your pee like the orange color, or your urine, sorry. I'm getting tired. So we'll also monitor symptoms, watching for improvement, decreased frequency, decreased urgency, dysuria. But we want to be quick to report any persistent or worsening symptoms. So we want to kind of be on the lookout for things progressing to a pyelonephritis. We want to be monitoring their input, intake, and output as well. Teaching for our patients, so medication, we want to teach to complete all of their antimicrobial, so we're preventing the recurrence and resistance. We want to encourage them to increase oral fluid intake unless things are like contraindicated, like with heart failure. This will help to flush out the bacteria and maintain a healthy urinary tract. But overall, just teaching your patient to recognize signs and symptoms of a UTI, reporting the urgency, frequency, dysuria, if they have any tinges of red to their urine, any pink, or if it seems to have a foul smell. We want to report these to our provider so we prevent that escalation and progression to a pyelonephritis and neurosepsis. So ways to teach prevention intervention is going to be to void regularly, do not delay urination. When you feel it, go ahead and go. Wipe front to back for females, empty your bladder after intercourse, avoid irritants like your, basically anything from Bath and Body Works, your bubble bath, your perfumed soaps, anything that, is really fragrant you want to avoid. Wearing cotton underwear, avoiding tight-fitting clothing, and if present, you want to teach good catheter care. Okay, so next we have the obstructed urine flow. This is always going to be significant, whether it's partial or complete. It can be like unilateral or bilateral, meaning like it could be obstructed coming from one kidney or both kidneys. So this can develop rapidly or slowly. So basically, if you get the gist, it can kind of look like anything. But we're worried about is that backward pressure damaging the kidney tissue. There's a pretty good picture that is coming up. Okay, so urethral strictures. This is going to be where the urethral lumen is narrowing due to scar tissue. What can cause that is injury, STIs, tissue trauma from catheters, or surgical instruments, cancer, enlarged prostates. We see the strictures a lot more in men than women. Signs and symptoms to look for would be a diminished urinary stream, dysuria, frequency, frequent UTIs. Treatment of this is usually going to be catheterization, urethral dilation, an endoscopic urethrotomy, urethroplasty, or a stent placed. Okay, so we are getting into the renal, gotta change it. Okay, getting into renal calculi. So these are going to be the formation of hard, small stones, so crystals in the urinary tract. Calculi is kind of the general term for these stones. We have a couple different types. So nephrolithiasis, that's going to be a kidney stone, and uretero, however you say it, this one, ureterolithiasis, that's going to be your ureter stone. Okay, our cystolithiasis, that's not listed there, but that's going to be the one in our bladder. But these are going to be less common. Okay, so these stones are made of like calcium, it can be uric acid, struvite, cysteine. You don't need to know those things, but they can be made up of all sorts of stuff. So this is going to be clinically significant to us because the obstructive urine flow, it's going to lead to pretty severe pain. Severe pain from this can sometimes be referred to as renal colic. It can cause hematuria, infection, hydronephrosis, and kidney damage. So what I want you to know is that you can get these. I hope I'm getting ahead of myself. All right, let me take a minute. Okay. So here we have that picture where you can see that we have that stone obstructing, and so it's kind of backing up and then causing swelling. So that's what would be causing that colic, that severe colicky flank pain that can radiate to your groin. So the hydroureter, that's going to be the dilation of the ureter above, so here, due to the backup of urine. So our bladder stones, they're going to form in the bladder and often be related to urinary stasis, or infection or catheter use. Our urethral stone, that is going to be more rare but caused by urinary retention and painful, or it's going to be more rare in causing urinary retention and painful urination. So I think if you have flank pain, it's more than likely going to be up here in your kidney. If it's more in your lower abdomen, radiating to your groin, it's more than likely a urethral stone. And then if you have the difficulty voiding, I would think bladder or your urethral stone. I misspoke up here, ureteral stone. Okay, I think that would be a good test question to try to be able to name what kind of stone. So next we have our pathophysiology. So those concentrated urinary salts start to settle out. Those salts that I was talking about, the calcium, the oxalate, uric acid, they settle out of solution and then start to crystallize. So these crystals start to aggregate into stones, and then we have the stones that can form in the kidney, ureter, and bladder, like you were shown on the picture before. So stones that are less than 5 millimeters, and this is something that I would know for a future question. Stones that are greater than 5 millimeters, these are usually going to pass spontaneously in urine. Stones greater than 5 millimeters, they can obstruct urine flow and cause severe pain. These are your ones that will lead to infection, and your large or staghorn calculi. So these are the ones that are like, staghorn means kind of like horseshoe shaped, I think. I don't really know what a staghorn is, but I just know that it kind of like, I don't know, it's kind of like C-shaped or something. You'll have to look it up. So these are often going to have to go in and surgically be removed. Okay. We have a few options. They could do the lithotripsy on that, or go in with a ureteroscope and take it out. So the severity of the pain doesn't always correlate with how big it is, because those staghorn stones, those large ones, can be pretty big. Okay, our etiology for our renal calculi, we have our heredity, family history is going to increase your risk. Chronic dehydration, so concentrated urine, is going to promote those crystal precipitation. And then dietary factors, high sodium, sugar, animal protein, that's going to increase your risk. Obesity is going to be linked with metabolic changes and stone formation. Infection from the recurrent UTIs that can lead to the struvite stones. So men are going to more commonly be affected than women. Peak incidence is going to be around 20 to 50, and then recurrence is common without lifestyle modifications. So always emphasize that hydration and dietary management whenever you're discharging these people and teaching. Okay, so next, some signs and symptoms of the nephrolithiasis. We have that costovertebral angle pain. Sometimes it's abbreviated in these slides, I think, is like CVA pain. But that's what that means. That was the back that I tried to show you. Hematuria, and then for the ureterolithiasis, that's going to be flank pain. It can be on your side or lower abdomen. It can be pain that radiates to the genitalia, having a intense urge to void. Frequency, dysuria, reduced urine output if obstructed. The hematuria, again, systemic symptoms. We can have nausea and vomiting, and this is often going to be from the pain. You can have restlessness. Your patients may look like they need to pace around, change positions constantly. So usually it's the movement of the stone that's going to cause us the most pain. So even, your smallest, it doesn't always matter how big the stone is. It's that movement and where it is that's going to be what's, causing the excruciating colic. Your patients with the large staghorn ones, they may be pretty just laying in bed, but usually those ones that are greater than 5 millimeters that are kind of on the move, those are going to be the ones that have people rolling around hollering. Okay. So signs and symptoms of bladder stones, that's going to be the hematuria and the oliguria. So that's, again, low urine output. So that low urine output is going to be from when a stone's obstructing the bladder outlet. Okay, so these stones are often from urinary stasis. Okay, so prevention for this, you want to teach your patients to be drinking adequate fluid. So unless it is contraindicated, you want to encourage them to drink 2 to 3 liters per day. That's going to help dilute the urine and prevent that crystal precipitation. So goal is to be at like a light yellow to clear urine. Diet-wise, you want to treat them or tell them to reduce their sodium intake. So our high salt intake is going to promote calcium stone formation. We want to limit animal protein and excess sugar, and then increase our intake of citrus. We want to modify our diet based on the types of stones that we're having. So if you have like the calcium oxalate stones, you would want to limit oxalate-rich foods such as like carrots, sweet corn, things like that. I think kiwi is another good one. So we want to have them exercise as well, if not contraindicated, to promote bone health and reduce that calcium release. So mainly you're wanting to try to, it's not a one size fits all. Try to, if you can, find out the kind of stones that you're having and then streamline it to that. Okay, so next we're looking at diagnostic tests. And like I said, in a quiz or exam situation, you're going to have a list of normals, okay? This is where you might have like a set of labs where you're given the information. So you have your normal range, so don't spend your time looking at normal ranges. Spend your time looking at, can I pick out which, like if it's going to be elevated or decreased. So I would know what those would be. So your calcium, uric acid, your BUN, and creatinine, those are going to be elevated whenever we have a high stone risk in kidney function. Our urinalysis, that's going to detect hematuria, crystals, abnormal urine pH. We do that urine 24-hour urine collection. This says ×2 for those. We can get a non-contrast CT, that helical CT scan. That's going to be our gold standard, our go-to for detecting stones. Our renal ultrasound is going to be useful for the patients that should avoid radiation. So a good example would be like your pregnant patient with a kidney stone. Your abdominal X-ray or KUB, So that's going to detect some stones, especially if they're like calcium containing. Sometimes it can miss some kind of like radio translucent, or however it's put, so it can miss some stones, but know that it can see your calcium containing ones. Then we have the IV pilogram. So that's going to be a lot less used today. We're going to use that CT without contrast. This one is going to be your gold standard go-to. Okay, so therapeutic interventions, if it's a small stone, we're going to hope that that's going to pass spontaneously. Management's going to include hydration, analgesics if needed for the pain relief, and then you can use an alpha blocker, so something like tamsulosin. That's going to relax your ureteral smooth muscle and kind of let that stone pass on out. Okay. For large stones and symptomatic stones, we're going to do some more aggressive treatment here. So that's going to be our IV fluids to help maintain hydration and urine output, and then pain control. We can use opioids such as morphine, NSAIDs. It can help with the renal colic. Thiazide diuretics that can help reduce the urinary calcium. So if we have our calcium-based stones, our thiazide drugs are going to be good for that. And then allopurinol, that's going to lower our uric acid. So if we have uric acid stones. Okay, so those are some kind of unique characteristics right there. So I think those would be good medicines to know. There's not several meds throughout this whole test that you need to know, but I'm going to leave you guys in charge of knowing those, what kind of stone that they're going to help. So thiazide is going to be the calcium stone. Allopurinol, that's going to be your uric acid stones. So next we have the lithotripsy. That's going to be where you're on this, like, let me see the picture. Okay, so you're on this like table and you have these like water bags and it's going to shake you. It's very, explaining it's odd. I would try to go look up a video of it if you can. So I'll try to explain it the best I can. You have this like shockwave generator, okay? So that's going to produce these high energy waves. Then there's like a reflector that helps to focus it onto the stone. And so you're using like the water column, these bags, to help conduct sound waves into the body. And then your monitors are helping you guide it. It's kind of crazy. So I think I can't really put that all on a picture. Try to look up a video of it. Maybe you can find one on like TikTok that's quick. So for this, you want to make sure, so important things for this procedure, you want to have your patient on some monitoring. So you want to have their heart monitor on, because this can sometimes trigger arrhythmias. Another thing is you may need sedation or analgesia during this procedure. It can be, depending on the stone type, it can be pretty painful. Post-procedure, we want to monitor for hematuria, flank pain, and stone fragments in the passage. I don't know if you've experienced this with working in healthcare yet, but sometimes whenever they'll have you strain the urine, you have that little cup, kind of looks like an oil type thing, oil funnel, and it has like a screen on the bottom. So you're taking their like their little hat and then pouring the urine through there to try to get the stone. So that's straining for a stone. So this shaking, it like shakes it to break it up, the lithotripsy, and then you might get the fragments out like that. So you want to encourage fluids after to flush those fragments. Okay, I think I'm going to stop there and post what I have for now, because it's like 1:30 a.m. So I'm just starting to sound ridiculous. So we will pick up at well, do I want to do surgery and contraindications? No, there's still way too much. So we're going to stop right there, and I will post what I have and then pick it back up.